Hello everyone, today we'll be discussing management of severe acute malnutrition. So this is the second video in the series of severe acute malnutrition. In the first video, we discussed the assessment and diagnosis of severe acute malnutrition, and in this one we'll discuss the management. So we start with conducting an appetite test on patients that we suspect or that we know have severe acute malnutrition. So, if the patients pass the appetite test and they're clinically well and alert, they should be treated as outpatients for uncomplicated severe acute malnutrition. Children who have severe edema or poor appetite, that is, the ones that fail the appetite test, or present with one or more general danger signs or medical conditions requiring admission, should be treated as inpatients. On admission, a child with complicated severe acute malnutrition should be separated from infectious children and kept in a warm area where a temperature is maintained between 25 to 30 degrees Celsius or in a special nutrition unit if available and constantly monitored. The general management for triage assessment of children with severe acute malnutrition and management of shock. When there is corneal ulceration, you give vitamin A, instill chloramphenicol or tetracycline and atropine drops into the eye, cover with a saline-soaked eye pad and bandage. If there is severe anemia that requires urgent treatment. General treatment of severe acute malnutrition involves 10 steps, which is divided into two phases. So there's the initial stabilization phase and then there's a rehabilitation phase. So this table shows the time frame for the management of a child with complicated severe acute malnutrition. So day 1 to 7 is the stabilization phase, and then weeks 2 to 6 is the rehabilitation phase. So the management of severe acute malnutrition consists of treating and management of hypoglycemia, hypothermia, dehydration, electrolytes infection. This starts from day 1 and goes all the way through the stabilization as well as the rehabilitation phase. Then management of micronutrient deficiency. So in the first week when we're replacing micronutrients, we do not give iron. We only start administering iron from the second week. Initiate feeds, usually you start that from stabilization phase. Catch-up feeding usually starts in the rehabilitation phase. Sensory stimulation starts from day 3. And preparing for follow-up usually starts from week 2. So we start by managing the first sign or symptom of severe acute malnutrition, which is hypoglycemia. So all severely malnourished children, they are at risk of hypoglycemia, and immediately on admission they should be given a feed or 10% glucose or sucrose. Frequent 2-hourly feeding is important for such patients. Diagnosis of hypoglycemia. So if there is any suspicion of hypoglycemia and when blood glucose can be measured quickly, this should be done immediately. Hypoglycemia is present when the blood glucose is less than 3 millimoles per liter, which is less than 54 milligrams per deciliter. If in some instances blood glucose cannot be measured, it should be assumed that all children with severe acute malnutrition are hypoglycemic and they should be given treatment. Treatment involves 50 ml of 10% glucose or sucrose solution. That is 1 teaspoon of sugar in 3 tablespoons of water orally or by NGT. So you just start by administering glucose, a bolus of glucose solution, then thereafter you follow by the first feed as soon as possible. So give the first feed of F75 therapeutic milk if it is quickly available, and then you continue with feeds every 2 hours for 24 hours. Then you continue feeds every 2 to 3 hours day and night. If the child is unconscious, you treat with IV 10% glucose. You give this at 5 ml per kg, or if IV access cannot be quickly established, you can give 10% glucose or sucrose solution by NGT. If IV glucose is not available, you can give 1 teaspoon of sugar moistened with 1 or 2 drops of water sublingually, and repeat every 20 minutes to prevent relapse. Children should be monitored for early swallowing, which leads to delayed absorption. In this case, another dose of sugar should be given. Then you continue with 2-hourly oral or NG feeds to prevent recurrence. Then start patient on appropriate IV or IM antibiotics. Monitoring of blood sugar. So if the initial blood glucose was low, repeat the measurement after 30 minutes. If blood glucose falls to less than 3 millimoles per liter, you repeat the 10% glucose or oral sugar solution. If the rectal temperature falls to less than 35.5 degrees Celsius, or if the level of consciousness deteriorates, repeat the blood sugar measurement and you treat accordingly. So how do you prevent hypoglycemia? You need to feed the patient every 2 hours, starting immediately, or when patient is dehydrated, you start by rehydrating first. Continue feeding throughout the night. Encourage mothers to watch for any deterioration, help feed and keep the child warm. Then check for abdominal distension. Second point to manage is hypothermia. So hypothermia is very common in malnourished children and it often indicates coexisting hypoglycemia or serious infection. If the auxiliary temperature is less than 35 degrees Celsius or it does not read on a normal thermometer, you need to assume hypothermia. Management of hypothermia. So all patients should be treated accordingly. So feed the child immediately and every 2 hours unless they have abdominal distension. If dehydrated, rehydrate first. Then you start by rewarming the child. So make sure the child is clothed, especially the head. Cover with a warm blanket and place a heater. You need to make sure that the heater is not directly facing the child. Okay? Or what you can do is you can put the child on the mother's bare chest or abdomen. So that gives rise to skin contact and cover them with a warm blanket or warm clothing. Keep the child away from draughts and then give appropriate IV or IM antibiotics. For monitoring, you check the child's rectal temperature every 2 hours until it rises to above 36.5 degrees Celsius. Then if a heater is being used, you check every 30 minutes. You need to ensure that the child is covered at all times, especially at night. Keep the head covered, preferably with a warm bonnet to reduce heat loss. Then whenever you find hypothermia, always check blood sugar. Prevention. So you feed immediately and then 2 to 3 hours day and night. You need to place the patient in a warm, drought-free part of the ward and keep the child covered. You can use the kangaroo technique for infants. Cover with a blanket and let the mother sleep with the child to keep the child warm. Avoid exposing the child to cold, such as bathing. Change wet nappies, clothes, and bedding to keep the child and the bed dry. Dry carefully after bathing, but do not bath the patient if the patient is very ill. Use a heater or lamp with caution. Do not use a hot water bottle or a fluorescent lamp. Dehydration. So, diagnosis of dehydration. So, this tends to be overdiagnosed and its severity overestimated in children with severe acute malnutrition because it's difficult to determine dehydration accurately from clinical signs alone. So, you need to assume that all children that have watery diarrhea or reduced urine output have some dehydration. It's important to note that poor circulatory volume or perfusion can coexist with edema. Treatment. So you need to try and not use the IV route for rehydration unless if the child is in shock. Rehydrate slowly either orally or by NGT using oral rehydration solution for malnourished children. So you start by using 5 to 10 ml per kg per hour up to a maximum of 12 hours. The standard WHO solution for general use has a high sodium and low potassium content, which is not suitable for severely malnourished children. So in this case, what you do is you give a special rehydration solution for malnutrition, which we call Rizomol. So give the Rizomol rehydration fluid orally or by NGT more slowly than you would when rehydrating a well-nourished child. So what does that mean? So you give 5 ml per kg every 30 minutes for the first 2 hours. Thereafter, you give 5 to 10 ml per kg per hour for the next 4 to 10 hours on alternate hours with F75 formula. Then the exact amount of how much Rizomol you'll give it will depend on how much the child wants, the volume of stool loss, and whether the child is vomiting. If it's not available, you can give half-strength standard WHO oral rehydration solution with added potassium and glucose. If rehydration is still required at 10 hours, give starter F75 instead of Rizamol at the same times. Use the same volume of starter F75 as of Rizamol. If patient is in shock or severe dehydration but cannot be rehydrated orally or by NGT, in that case you give IV fluids. So the fluids of choice are either Ringer's lactate with 5% dextrose or half-strength Diarrhea solution with 5% dextrose. If neither of the above is available, you can give 0.45% saline with 5% dextrose. Monitoring. So during rehydration, respiration and pulse rate should fall and urine should start to be passed. The return of tears, a moist mouth, less sunken eyes, and fontanelle, and improved skin turgor are also signs that rehydration is proceeding. But many severely malnourished children will not show these changes even when they are fully rehydrated. So monitor the progress of rehydration every 30 minutes for 2 hours, thereafter every hour for the next 4 to 10 hours. You need to be alert for signs of overhydration, which is very dangerous and may lead to heart failure. So you need to check for one, weight gain to ensure that it is not quick and excessive. You need to check for an increase in respiratory rate, pulse rate, frequency, enlarging liver size on palpation, and the frequency of stools and vomit. Electrolyte imbalance. All severely malnourished children have deficiencies of potassium and magnesium, which may take about 2 weeks to correct. Edema is partly a result of potassium deficiency and sodium retention. Do not treat edema with a diuretic. Excess body sodium exists even though the plasma sodium may be low, so giving high sodium loads could kill the child. Treatment of electrolyte imbalance, so you need to give extra potassium about 3 to 4 millimeters per kg per day, extra magnesium at about 0.4 to 0.6 millimoles per kg per day. The extra potassium and magnesium should be added to the feed during its preparation if it's not premixed. When rehydrating, you need to give low sodium rehydration fluid, which is the Rizamol. Then prepare food without added salt. Infection. In severe acute malnutrition, the usual signs of bacterial infection such as fever are often absent, yet multiple infections are quite common. Therefore, assume that all children with severe acute malnutrition have an infection on their arrival in hospital and treat with antibiotics immediately. Hypoglycemia and hypothermia are often signs of severe infection. So treatment, so give all severely malnourished children a broad-spectrum antibiotic, measles vaccine if the child is more than 6 months old and not vaccinated or was vaccinated before 9 months of age. Delay vaccination if the child is in shock. So for the choice of broad-spectrum antibiotics, if the child has uncomplicated severe acute malnutrition, give oral amoxicillin for 5 days. If there are complications such as hypoglycemia, hypothermia, or the child looks lethargic or sickly, or any other medical complication, you give parenteral antibiotics. So the choice can be benzyl penicillin or ampicillin. For 2 days, then you give oral amoxicillin, plus gentamicin for 7 days. These regimens should generally be adapted to local resistance patterns. So that basically means that the choice of antibiotics can be varied based on the local resistance patterns of the specific area where you are. Then of note is that metronidazole can be given thrice a day for 7 days in addition to broad-spectrum antibiotics. Then you treat any other infection as appropriate based on the clinical examination. Then treatment for parasitic worms. If there is evidence of worm infestation, treatment should be delayed until the rehabilitation phase, which is at least a week after admission. Give albendazole as a single dose or mebendazole 100 milligrams orally twice a day for 3 days. In countries where infestation is prevalent, also give mebendazole to children with no evidence of infestation 7 days after admission. Micronutrient deficiencies. All severely malnourished children have vitamin and mineral deficiencies. Although anemia is common, you do not give iron initially, but you wait until the child has a good appetite and starts gaining weight, which is usually in the second week. That is because iron can make infections worse. Multivitamins including vitamin A and folic acid, zinc and copper are already present in F75, F100 and RUTF packets. When premixed packets are used, there is no need for additional doses of the above. Then treatment for vitamin A deficiency. So give vitamin A on day 1 and repeat on days 2 and 14 only if child has any signs of vitamin A deficiency. So what signs are we talking about? Like corneal ulceration or history of measles. So if the child is less than 6 months, you give 50,000 international units. If the child is 6 to 12 months, you give 100,000 international units. If the child is more than 12 months, you give 200,000 international units. Then for iron, you start at 3 milligrams per kg per day after 2 days on F100 catch-up formula. Do not give iron in the stabilization phase, and do not give iron if the child is receiving RUTF. However, of notice, if the child is not on any of the pre-mixed therapeutic foods, you give the following micronutrients daily for at least 2 weeks, which is folic acid at 5 milligrams on day 1, then 1 milligram daily, multivitamin syrup at 5 ml, zinc at 2 milligrams per kg per day, copper at 0.3 milligrams per kg per day. And we go to the initial refeeding. So in the initial phase, refeeding should be gradual. So treatment, the essential features of initial feeding are frequent, every 2 to 3 hourly oral small feeds of low osmolality and low lactose. NG feeding if the child is eating less than 80% of the amount offered at 2 consecutive feeds. Calories to be given at 100 kilocalories per kg per day, protein at 1 to 1.5 grams per kg per day, liquid at 130 ml per kg per day or 100 ml per kg per day if the child has severe edema. In addition, if the child is breastfed, encourage continued breastfeeding, but make sure the prescribed amount of starter formula are given. So monitoring amounts of feed offered and left over, assess for vomiting, check the stool frequency and the consistency, and do daily body weight checking. Catch-up growth feeding. Children in the catch-up phase should in most cases be managed as outpatients. Signs that a child has reached rehabilitation phase for catch-up growth are if the patient has a normal appetite, no episodes of hypoglycemia, and there is reduced or disappearance of the edema. Treatment. So you make a gradual transition from starter F75 to catch-up formula, which is F100 or RUTF, over 2 to 3 days as the patient is tolerating. Then replace starter F75 with an equal amount of catch-up F100 for 2 days. Then give a milk-based formula such as ketchup F100 containing 100 kilocalories per 100 ml and 2.9 grams of protein per 100 ml or RUTF. On the third day, if on F100, increase its successive feed by 10 ml until some feed remains uneaten. The point at which some feed remains unconsumed is likely to be when intake reaches about 200 ml per kg per day. After a gradual transition, give frequent feeds of unlimited amounts, 150 to 220 kilocalories per kg per day, 4 to 6 grams of protein per kg per day if on RUTF. Start with small but regular meals of RUTF and encourage the child to eat often. If the child cannot eat the whole amount of RUTF per meal in the transition phase, top up with F75 to complete the feed until patient is able to eat a full RUTF meal. If the child cannot take at least half of recommended amount of RUTF in 12 hours, stop RUTF and give F75. Then you try reintroducing RUTF again in 1 to 2 days until the child is able to take adequate amounts. If patient is still breastfeeding, offer breast milk first before every RUTF feed. After the transition phase, refer the child for rehabilitation in outpatient care or to a community feeding program. Wash hands before giving feeds, sit with the child on the lap and gently offer the feeds. Then try to encourage the child to eat the RUTF without forced feeding. Offer plenty of clean water in a cup when the child is eating RUTF. So for monitoring, you need to avoid causing heart failure. Monitor for early signs of congestive cardiac failure such as a rapid pulse, fast breathing, basal lung crepitations, enlarging liver, gallop heart rhythm, raised jugular venous pressure. If both pulse and breathing rates increase, breathing by 5 breaths per minute and pulse by 25 breaths per minute, and the increase is sustained for 2 consecutive 4-hourly readings, then you need to reduce the volume feed to 100 ml per kg per day for 24 hours, then gradually increase as follows: 715 ml per kg per day for the next 24 hours, and then 130 ml per kg per day for the next 48 hours. Thereafter, increase each feed by 10 ml as was described earlier. Then sensory stimulation, so provide tender loving care, cheerful stimulating environment, structured play therapy for 15 to 30 minutes per day, physical activity as soon as the child is well enough, then support for as much maternal involvement as possible, and provide suitable toys and play activities for the child. And for discharge, inpatient care can be transferred to outpatient care if all clinical conditions or medical complications, including edema, are resolved, or the child is clinically well and alert. The child is breastfeeding effectively or feeding well. Weight gain is satisfactory, which is above the median of the WHO growth velocity standards, or more than 5 grams per kg per day for at least 3 successive days. Before discharge, the infant's vaccination status and other routine interventions should be checked and provided as appropriate. Mothers or caregivers should then be linked with any necessary community follow-up and support. A child should only be discharged from all nutritional care only when he or she is breastfeeding effectively or feeding well with replacement feeds, and has an adequate weight gain and has a weight for length equal or higher than -2 Z scores. So that's all about management of severe acute malnutrition. Thank you.